Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable.
And welcome to everybody out here. We are live at EMS World Expo, the International Scientific Symposium. And this is the September 2023 Pre-Hospital Care Research Forum Education Research Journal Club. Thanks to our big audience out there. You guys, can you clap so they can hear like how many people? We got all these live people and we have some people on Zoom. Welcome. What we're going to be doing today, we're going to talk a little bit first about what's been going on at EMS World with our fearless leader, David Page. I'm here with Michael Caduce and a room full of folks here and so you out there. And we're bringing to you a journal club and some information about our International Scientific Symposium. Okay, so off to the races now. It's been a great couple of days in New Orleans. So we are at the tail end, little tired, but never too tired to look at some more research. And this article that we picked for our September PCRF Education Research Journal Club is entitled Pre-Hospital Pediatric Emergency Training Using Augmented Reality Simulation, a Prospective Mixed Method Study. So this is a study out of Stanford. So out in my neck of the woods, I'm in San Francisco, so they're just south of us. Mountain View Fire Department participated in this, a nice, small kind of feasibility study for augmented reality use in pediatric education. And it's a continuing education study. So sometimes we look at the basic EMT or paramedic or initial education, kind of the pre-licensure, pre-certification level. This is actually part of continuing education. So we'll keep that in mind as we go. And Michael, you chose this article. So I'm wondering if you can start us off by saying, what caught your eye? This is in pre-hospital emergency care. Unfortunately, I think it's not open access. But you can figure out a way to get it.
Well, we're going to give them all the details, so they're going to know exactly what the study said here before the end of the day. Actually, this is a great article and great research, and I think the goal of all of our research articles is to find something that has methods that are valuable, and this has valuable methods. It's a great thematic analysis that we'll get into the details on. We like it because it's new and it's shiny, and I think as EMS providers, we like new shiny things. Augmented reality is something that's going to come likely to all of our classrooms at some point in time. What we need to know is how do we take the technology and best implement it into our classrooms, and this study starts looking at that in the continuing education environment. So I like that. I like any study that's recreatable, and they gave you everything in this study. So there's an appendix with the questions they asked. There's all their tables. There's all their data. They even went through the scenarios that they went through, the one scenario that they went through. So I like that. I think any classroom, any continuing education provider could actually replicate this if they had the augmented reality technology. And actually, this study even tells you what augmented reality technology they used and talks about how you go about getting licensure for it. So for all of those reasons, I like it. We need to know how we're going to implement this technology in our classroom in the future. And it's new and it's shiny, and we like new shiny things.
Yeah, and it has to do with deeper learning, right? So we know that we were just talking about this in a previous session, and Aaron Donathan's here, has done virtual reality research. We had a great discussion about active learning strategies, how it's more equitable teaching. You see better results all around and improve retention, not just passing the test, but retaining those skills with deeper learning and certain pedagogies or teaching techniques that will engage the student deeply. And certainly augmented reality, virtual reality can immerse you into, I guess when done properly and all those other things, right?
Yeah. This isn't just
anchored
skills.
in objectives.
Skill sheet.
Yeah.
And then I think that's one of the other perks of this study is they're very clear on what their objectives were and what they started out trying to do. And as educators, learning objectives are our baseline and where we start from. So should we dive into it?
Yeah, sure. So they give us the background, which I think all of us, there's no tough sell on the background of needing to know how to run a pediatric critical patient call. And so they talk about the high stakes, low frequency environment around EMS calls and pediatric patients. And that the competence tends to decay. There's a lot of evidence that very quickly after training, even within 6 weeks to 3 months, you start to see decay in procedural skills, performance, and even knowledge decay. And I really appreciate that they mentioned clinical anxiety. So they said, decay due to limited skills practice, attrition of those skills, and clinical anxiety around these calls. But they said there's also barriers to this kind of, providing good ongoing training. Some of that's funding, having the expert personnel and consistent training across those personnel, right? And then the time. So that's another thing that's come up with virtual reality and augmented reality is the idea that you can standardize something without having the interference of, the different techniques or opinions of instructors. So I think that was a really good point. So then they decided that, and they point to, augmented reality, virtual reality training, having that, potential to be one of the ways to teach and interact and make it kind of deeper learning. They also mentioned that it's already been integrated into the 4th edition rollout of PEP, of the Pediatric Education for Pre-Hospital Professionals course. And then, but no one's really done specific studies about, whether or not people are using it, how useful is it, although Erin gave us a little bit of her research on that today. They used something called the CHARM. It's a proprietary simulator. CHARM is Chariot Augmented Reality Medical Simulator. So that's CHARMS, I guess, CHARM from Stanford University. And then they talked about the software licensing that you can get through a nonprofit organization in Vinci Kids in San Bruno, California. So again, they point right to where we could actually did you access it yet?
I did not go look at it. Though when I pulled this article, I was like, this looks like you could do this. I thought it was also interesting. So they do differentiate in their introduction the difference between virtual reality, VR, and AR. And so I think sometimes we interchange these words. It is probably worth noting that in this study, their definition of augmented reality blends visual images with real elements. So they are actually going to use some of the medical simulation equipment that we would have, a bag valve mask, for example. I think they mentioned a glucometer and some things like that. So I think it's worth noting that this isn't necessarily the hand controlled like Oculus glasses that I sometimes think of. So there is some actual blend here.
Yeah, that's an important point. And we've looked at augmented reality in the past on a couple of studies, especially there was one out of Australia that we looked at, I believe, that had augmented reality. They sent out 3D printed laryngoscopes to students in rural areas and had them practice using a program on their iPhone that they could drop into a pair of glasses, and they could get some haptic feedback even in some ways. So that haptic feedback to give more of a sense of reality is really important. But yeah, that's an important point. What is virtual versus augmented, and where do you blend them? So the purpose of their study then was just to explore the utilization of this AR software for EMS training using a qualitative and a quantitative approach. So that's what the mixed methods is all about. And the primary aim was to determine the acceptance of AR simulation among pre-hospital clinicians using semi-structured interviews. And then secondarily, they wanted to evaluate the usability and the ergonomics. So, sometimes I see things and I think, okay, give somebody a toy and ask them, whether they like the toy, and it's a fun toy, people are going to say, yeah, it's really fun. But I think it was really good that they went into greater detail. They looked at also usability. I mean, is it practical to use in training? And then what about the ergonomics? Because a lot of people talk about, I get nauseated. It's not, necessarily something that I can feel comfortable doing.
Yeah, I'm really impressed with the number of things they asked and sort of looked at. So when we get to the results, we've got a whole bunch of them. I thought it was interesting too in their methods. They set up a scenario that has already been fairly well validated. So the simulation scenario that they put their augmented folks through was a child with a hypoglycemic induced seizure. And I can definitely say I think that would increase the cognitive load on an experienced paramedic and EMT without a doubt. It was a adapted from a scenario that was previously used in the PD STEPS program and taught over 550 pre-hospital clinicians using high fidelity simulators. So I think good to use a scenario that's been well validated and well used. This isn't just something we made up in our backyard and we're going to throw our students into today. We have some certain expectations around what's going to happen. They put some folks through this and then they asked them some questions at the end. And I think that's really how they drew their conclusions and how they drew their results, was a thematic analysis of the interviews with the folks after they participated in this scenario.
Yeah, so it was prospective mixed methods. What you're seeing on the screen now is, and this is an image in the article, what the actual image would look like. You'd have a pediatric patient, and you can see that they can attach things. They could actually use some equipment. There was no mannequin. That was one thing that they mentioned later. There wasn't a mannequin there. So there was this augmented reality or virtual reality image of the patient. And then what you're seeing is kind of the overlay into the real environment. So you see the oxygen tank, you see, a crash cart. And there's another comment that was made by the EMS providers later that they did this very kind of hospital-based, a monitor, the baby, you see the BVM, and then a little red marker there that's designed to kind of situate them in the real kind of world surrounding. So you're seeing this kind of overlaid into this. So now you have this simulation of a pediatric patient having a seizure. They were to go through they were instructed, not for very long really, on how to use this, how to interact and what to use. They had an actual IV set up. They had actual medications to draw up so they can see their real environment around this kind of augmented imagery. And so that's what they were working with. It was one-time simulation. So I think there's 22 participants in this, and it's a one simulation. At some point they talked about, and I'm not sure if I'm getting this right, but they talked about going from the seizure to now cardiac arrest.
I saw that too, because they said they didn't have a compression mannequin to do the chest compressions on. And I was a bit concerned on how the hypoglycemic seizure patient made it to cardiac arrest. Or if that
and
was
a VFib arrest.
Yeah, if that was a negative outcome of not treating the patient. And I didn't see necessarily how we got there. I could see if maybe you weren't treating the patient, they had built that into the scenario since they were using a pre-approved scenario. So I wondered that too. I felt bad that cognitive load's already pretty high, and now the patient is coding and it's a pediatric patient. Yeah.
And I don't know how prepared they were with the simulation, whether it was just you're going to a pediatric patient with a seizure. And like you said, did they know what was going to happen ahead of time? Since the study was really not about their actions as it was about, and their performance as it was about their judgment of whether or not this is usable. So they had to apply their clinical reasoning skills. They had to, communicate with their team. So there was some of that. They had to make decisions. All of those things were integrated into this. They also, interestingly, inserted a parent actor.
I thought the other interesting part that I loved about the methods was they excluded anyone that had extreme motion sickness.
Yeah.
And I was like, well, I guess if you're going to do this seems like a good exclusionatory criteria. But yeah, they had a parent actor in there, and I wondered one of the things, because I think so this is the slide of them. I wondered how they see each other, right? You can see the mannequin, you can see the crash cart, you can see the vital signs. It doesn't really dictate in the methods if you see each other doing the skills, or if this parent was something they could see or just hear. Yeah. I wondered that too, because that would definitely, again, increase my cognitive load.
They did say, I remember one of the comments in there was, it felt weird not being able to make eye contact with my partners. So I had to verbalize. Someone had said it forced me to actually verbalize more, forced me to delegate, forced me to do closed loop communication, which they thought was a positive thing. And that comment was made more than once. So so that's interesting. I can't sort of envision it. Like if I was wearing those goggles, can I see you can see the surroundings. So I would imagine you can see other people, but maybe the eye contact itself, the nonverbal communication that you use sometimes was not there. So. Okay, so we can, and you know what? I see we have some people. Whoops, we got some echo. Hang on. Okay. We have some people out there, but I'm not sure we'd be able to hear you. I see Dr. Bill Toon is out there, and I don't want to cause any echoes or anything. I'm not sure if we are able to unmute and hear you, but if we can't, if you could just keep using the chat, Mike's monitoring the chat area here. While I'm moving these slides out here. And anybody out in the audience too, if you guys have anything to contribute, just like you would in Zoom, if you want to raise your hand too as we go, if you have anything to contribute, go for it and we can bring you into the conversation. Okay. All right.
I think that brings us to our results. After the study, they did a thematic analysis and got some opinions. We should start with the characteristics of those people that were involved. You can see that up on the screen now. They had a nice breakdown of people that were involved in this. I think it did sort of match with what we've seen previously in demographics for EMS providers, where maybe our sample size wasn't as diverse as we would have liked it. The one thing I noted from the sample size that I appreciate is they put both EMTs and paramedics into the skill set. I always like to see us as an EMT educator as well. I like to see us, including our EMT colleagues in the simulation, because certainly there's plenty they can do for a hypoglycemic pediatric seizure / VFib arrest. What else did you find interesting in the demographics and the survey questions they asked, Megan?
Actually, the one that interested me the most, and I thought of Katie O'Connor on this one. I'm not sure if I saw Katie at the conference. I'm not sure if she's gone or around, but they asked whether they had experienced the number of times you've previously experienced augmented reality. Okay, well, not surprisingly, you're going to see some low numbers there. So when the number of, it was like 77% had never experienced augmented reality. Only 1 or 2 times there were 5 people who had experienced it 1 or 2 times, probably at the mall or something, right? And then greater than 2 times, nobody. So they were inexperienced in augmented reality, which was good because they wanted to see, is this feasible? And then the next question was the one that surprised me. And I'm not sure if this was misunderstood or worded in a different way, but the number of times you've previously experienced in-person simulation, live role-playing simulations, high-fidelity simulations, and 5 people said none.
Yeah, I thought that was
22% of the group said, I've never been involved in that. So are they?
And another 5 said only once or twice, which makes me think, what's your paramedic school doing? Or what's your EMT school doing to train you ready for it? Now, I think this is an interesting question, because I think if we ask people, how much high fidelity training have you had? People think high fidelity training is my $200,000 mannequin. When in fact, that's, we can do high fidelity simulation other ways. I did appreciate the years of EMS experience, Megan, and how they said they had a very diverse group of people. They had a couple people with just a 1 to 5 years of experience, a few more with 6 to 10. So they really had, of all their diversity and their demographics and experience here, that was definitely something they had. And I appreciate that. When we look at people and their adaptation to technology, we have early adapters, we have innovators, and we have people that are going to be holdouts. I think of when, who buys their iPhone and stands in line versus the people that wait till all the bugs get worked out of it. So they had some diversity in their experience, which I appreciated.
Yeah. And I don't think we can make judgments. I know it's real easy, and I do it, and I have to catch myself making judgments about age and technology level or interest, because I don't think it necessarily always follows that the younger they are, the more likely they are to have used augmented reality. But that helps to have this like widespread of years of experience. Something I feel like we should explain, since both of us work in California, is this is the Mountain View Fire Department, which is in California. You'll see the current EMS level, but you'll also see, national registry versus state certification. And you'll see very few actually maintain national registry. And that's because it's not required to maintain national registry in the state. So they did get their initial certification. They had to, because that's the state test. But they let it lapse because they're not required to maintain national registry, only state certification. So in case anyone's looking at this and wondering that's what that's all about, is the lack of requirement.
The next findings were their focus group findings. And again, we have a ton of data in here. Oh, which is the next table?
I didn't put that table in because it's so busy, but you can talk about that table too if you want.
It's sideways on my screen. So
it's sideways. So if you see us going like this.
this is our table 3. So this is the system usability scale. So these were some of the questions that they asked the participants, things like, I think I would like to use the system frequently. I found the system unnecessarily complex. So again, how easy is this to use? I feel confident using the system. And they provide some, agreeability scores. I do appreciate that they have a fairly positive view of these, and we can break them down as we go. But most people thought the system worked pretty well. There was 145 that stood out to me that said, I think that I would need the support of a technical person to be able to use the system. And I wonder if that had anything to do with the fact that it was a pretty quick orientation to the augmented reality, and the fact that very few people in the study had actually had augmented reality. There was another one that said, I thought there was too much inconsistency in the system. That was pretty low, which I appreciate for simulation.
Yeah.
I feel like every skills lab I fight that battle with, well, so-and-so said do it this way, so-and-so said not to. So I think they did a nice job on that.
And they didn't find it cumbersome to use,
Exactly.
which I thought was really, that was a great comment there too. So the support of the technical person, that also makes me think, well, maybe it's not an EMS educator necessarily that can be in the room. Maybe it can be an EMS, a teaching assistant, someone, maybe an EMT who knows how to use the equipment, rather than having the clinical expert in the room.
I thought that was interesting, and I wondered, you could feasibly make this the same person. You just need to be able to operate the glasses to run the study. Should we dive into the focus group findings?
Yeah, sure.
Quite a bit of them.
But the recording capability too of the system.
Oh, if you could record the actual augmentation, you're almost gonna have to run the cameras, record the augmentation, and record what's going on the ground, because
that would be kind of a funny recording to watch.
The equipment you can't see. So that I could see where that could impact your debriefing.
Yeah. What do you think, Dave? You're quiet over there. Busy typing. He's doing 7 things at once.
I also think that it might be interesting the way that this paper is describing simulation. The augmentation does not seem to be augmented; it seemed to be almost virtual, and so I almost think that the goggles, instead of it being here's what I'm thinking. In Singapore, I saw augmented reality being used with safety glasses, where you could layer an image on top of what you see, which is truly augmented. So you're able to see, for example, you arrive at a scene, you look at a mall, and you're able to see where the AED is, or you're able to see where the patient is, or you could look at a mannequin and the software is making the mannequin bleed. You follow me? So 100% they should be able to record that when you're interacting with multiple people, which is, I think, phenomenal. I think that's that's the ideal, is being able to work in teams, which is the advantage of this. The inability to interact with an object or with the other people in the room would be the limiting rate limiting factor, and recording it would mean recording 3 different performances simultaneously versus just a video of the event, and maybe the video is being recorded but the performance is not. Does that make sense? And I would want both of those to be recorded if I was going to make a judgment about performance. Does that work?
Competency.
And recording is now very common, and I would imagine that would be a limiting factor with something like this in terms of usability. And maybe recording at the continuing education level is not as common as recording at the initial education. What do you think?
That seems reasonable.
Yeah.
Less sort of requirements to maintain competency documentation.
That's interesting. The glasses you were talking about, they're like the Google glasses or something, where you put them on and the scene itself changes, right? And you're working within the context of the scene. I do love the teamwork, and that is one of the limitations that we've seen in some of the virtual things, is that the individual can interact, but the ability to interact with your team back and forth is limited, and maybe it's growing now, but it's been limited traditionally. So talk about the ergonomics one. Is that what our next one
Yeah,
I
we can
think
get
is
table 4, sure.
yeah.
So I thought so they also looked at ergonomics. Does the system work? Can you reasonably do this? If we have to push a cart behind you, it's not a very realistic ability of what's actually going on. So actually they had fairly low, most of the people did not agree with these comments, which are good because the questions were like, is it too bulky? Is it too heavy? Was the mental effort required for the device too high? People were saying no to those questions for the most part, only about 4% of people. So it's likely one participant. Head fatigue was very high. Nobody said that, which is nice. Eye fatigue got a little high for a couple people, looks like. And then they did ask if people would feel comfortable using the device for a long time, and 63% of people said they agree or strongly disagree. So more than half said that they would feel comfortable using it. I do think that's a valuable takeaway from this paper, because that's one of the things that we've seen consistently in our augmented and virtual reality is people get nauseous, they get sick, they get a headache, especially if they've had a history of that. And I do think if you've had a history of motion sickness, there's probably brings some anxiety into the situation. So I think that's worth noting. So I do appreciate that they asked people, would you continue using it? Do you feel like it could be used for for a long time period? I don't know what they define that as, but I would imagine that's like more than this, 10-15 minute simulation.
Yeah, and I'm wondering if getting used to it, is a factor. What happens over time? Aaron Donathan, you're out there. Have you found people getting used to virtual reality headsets?
So there's a term for it. It's called VR sickness.
VR sickness.
It's called VR sickness. There is not a lot of information out there about it because VR is still relatively new. You can find cities that have very high proportions of people that use it. In the most recent one that we ran, there was only about a 2% amount of population who experienced a headache or nausea with the glasses on. It's important with virtual reality that you have to take the headsets off every once in a while and take a break. It's very much like riding the virtual roller coasters or any of that stuff. If you're prone to migraines, if you're prone to any of those things, you have to watch yourself. But generally, especially for programs like this, which are stationary and not the video games where you're running through scenes, it doesn't tend to affect too many people. There's a higher level of nervousness about it, I think, than there is an actual instance of it.
Yeah, nervousness about the nausea. Nobody likes to throw up in front of other people. Right.
You'll have to repeat your comments from the audience.
Oh, sorry, audience. I wasn't sure if this microphone, I think we have it set directed toward us. Sorry about that. So Aaron Donathan has done a lot of research on virtual reality and continues to. So thank you for your research on it because it's such an important thing. But has found, about 2%, did you say, get the nausea? In her most recent one. So there's that degree of VR sickness but more of a fear of VR sickness than the actual results of it. But I'm just curious now too, as they get used to this platform, if it does prove to be beneficial, then, so this is feasibility.
This
right?
is feasibility. And actually part of the ergonomics was feasibility. I think technology acceptance was another thing that was interesting that they noted in the results. So we should say they themed this and they came up with several themes throughout the thematic analysis. This was not topics that they were looking for. These were topics that came out of the interviews. So they asked some specific questions with the focus group, which were the people that participated in the study. And they actually included that in the study. So they included exactly what questions they asked, and they adopted this from a previous study. So again, they're sharing the method so it can be repeated. So they found their thematic analysis included a general appraisal, a realism, learning efficacy, mixed reality feasibility, technology acceptance, software optimization, and then rare, but they noted it in the results, alternate use of cases. So we can actually look at each one of those things because they included what the participants said in the thematic analysis. Maybe we just go straight through each one. So they did, when talking to the participants, they looked at the general appraisal, which is what did people just generally think about this? Did it work for you in the situation? And they said 14 participants offered appraisals of the overall simulation experience. 12 of the participants positively described the experience. So again, it's a thematic analysis, which means we're looking at what people say. So 14 of the participants mentioned this. So they had some conversation about, it's it's feasible to do this. It's generally, you know, it works. 12 of the participants positively described the experience, referring to the experience as great, cool. And according to one participant, I have
night
this,
and day.
yeah,
I like that one.
yeah, night and day
better.
difference between what they've used with mannequins. So again, I think I always look for something that I can get buy-in with my students on. So the fact that the students are saying, yeah, this actually works, and there's buy-in, prevents the like, no, that was stupid, I don't want to do it anymore. That's helpful. They did realism was their next theme, if you will, and they found that participants consistently reflected on the realistic nature of the AR simulation. 8 of the participants commented that the ability to feel a pulse on the controller, listen to lung sounds, and to visualize a lifelike patient created a more realistic training environment than traditional simulation. And I think most of us would agree. We take our one standard 6-year-old mannequin, because that's the only pediatric mannequin most of us have, and we put it on the floor and we make it a 1-year-old, a 2-year-old, a 4-year-old, a 5-year-old, a 6-year-old, and however old they want to be. So I do appreciate that this simulation technology allows you to actually change that. You know, you're not walking into the same thing, which again raises that level of learning.
You could also insert cultural diversity into simulation more easily.
Absolutely.
When you have simulated mannequins or simulated people.
And difficult topics, right?
And difficult topics. Yeah.
Topics you wouldn't be able to do, assessments you wouldn't be able to do in a real person.
Well, that was I thought that was the cool thing about having the parent actor, was to insert that you had to, you know, you had to interact with the parent too. So that was another, and I think sometimes it took the students by surprise. I think that what came up in their results is that it took them a little bit by surprise.
That's what made me think it was just a voice overhead rather than an actual person that walked into the simulation.
Yeah.
Like the voice of God is talking to you while you're trying to resuscitate this pediatric patient, but it turns out it's a parent.
Yeah.
So I thought that was funny, or that was the connection I made in my mind. They also looked at learning efficacy, or this was the additional theme that was brought up. Participants consistently reported that the training simulation was a valuable method to promote learning. Again, we care about what students say after they learn something. Was it a good user experience? We know there's plenty of data that suggests when students have a good experience, they're more likely to learn. If they're scared, if they're nervous, if they're anxious, we don't get to the level of learning that we do if students are in a supported environment. Thus, we care what they have to say afterwards. Specifically, they said 8 participants noted that the experience promoted practice of pediatric treatment algorithms, medication dosing, that's something we can probably all use a little practice on. Scene management, task prioritization, and again, leadership. They're delegating roles. The American Heart Association's virtual ACLS and PALS does the same thing. We need you to be able to work well together as a team, and they've taken that into account in this augmented reality.
Yep. And prepare for the stress of the field. That one comment, it prepares us for the stress of the field.
Yep. Again, we're raising that cognitive load. We're giving hopefully some stress inoculation throughout the training.
Exactly.
Sorry, go ahead, Dave.
I guess one of the things that I feel like we need to move beyond is research that just says, I'm satisfied and it was fun.
Yes.
So what? I mean, great, it was fun. The measurement here and the call to action on the part of EMS researchers is, did it result in better care, in improved outcomes for educational outcomes or clinical outcomes?
But it's stepwise, right? So translational research in medical education is stepwise. So you have the first step, which is, you know, something like this. We use it. Is it feasible, usable? Do students, you know, will they use it? Did they learn in the sort of short-term thing? You might have a pre-test, post-test kind of thing. And then the next level, does it change practice? Does it actually change their practice in a clinical setting? And then the third level being, does it change the outcome of the patient? Do all of these things in a row change the outcome of the patient? Some say there's a fourth level, and that is, does it change outcomes in the community? So that's another great you know, consideration in it. So this would be at kind of even a piece of translation level 1. We're not even, and I'm so glad you mentioned that, because we talk about satisfaction surveys all the time. A lot of times as a faculty member, you're judged on what your students, you know, how they feel about you and how they're learning and whatever. But we also know that students oftentimes will rate methods of teaching that are not the best method for retention, for long-term learning and retention. So that's something we had to keep in mind. But to your point, the student has to be comfortable too. They got to be safe to learn. And so that's actually important piece.
Oh, I think that's incredibly important. And I agree. We see things on teaching evaluations like this was the most fun instructor. I'm like, that's great. I'm glad you had fun, but did you learn anything? So I think, again, as we look at what's the best educational practice, like, I don't like that you made me take a test. Well, okay, but at some point in time, we're going to have to do that. The next theme they found in their thematic analysis was the mixed reality feasibility. So the mixed reality feasibility domain referenced the participants' assessment of the feasibility of using real world objects together with the AR imagery. So again, their test, or the thing that came up in the conversation was the haptics, if you will. And we've talked about this on a couple other papers. The use of the BVM, the squeezing of the BVM, the connecting of the IV tubing, those type of things, the handles that simulate the pulse. The students want to have that hands-on connection, and I see that's probably even more important on the initial education side, but I think on the continuing education side it holds true. 12 of the participants reflected on the value of the training experience that blends both the visual and the physical elements, and I thought this participant actually summed it up. It's got to be a mix of both, which is what they did. Medicine is both cerebral and physical, and I thought, gosh, what a great cerebral comment to make.
Yes.
So good reflection on the fact that they're taking the hands and putting it together. They're not just sitting in a room tabletopping this. They're really truly trying to blend it together.
Yeah, the one thing though too, I appreciated was that they discussed the difficulty in seeing objects that we would consider pretty critical, like pediatric dosing charts. So that's I can imagine you can see the larger objects, but pulling up a pediatric dosing chart was not visible to them. And that would be a practical thing that you would use in a situation like that. I'm not sure how they got around that.
Yeah, and they also said one participant noted the safety concerns of using needles and other equipment that you can't see while wearing the headset. And I thought to myself, gosh, if I was going to change the simulation, I think I would probably try and eliminate the risk that someone's going to poke themselves with a sharp. Just again, if we're starting out to see, does this work? I may worry about that as well. So,
at some point, maybe we'll have something where you have simulated materials that aren't real needles. I looked at something out of Spain once that they were doing a CPR virtual reality where the headset, and you probably already have seen this, but the headset will detect hands. Not gloves, not joysticks, your hands, so that you can actually get the feedback on rate and compression directly, like headset to hands, to real hands. So I thought about that. Are there things that can be part of it that are not real, that are simulated without having to use the real thing?
But this is a really interesting space right now because of the new announcement from Apple and their new devices. I think the new Apple Watch, you now are going to be able to just tap with your finger, right? So the Apple Watch will detect your clicks with your two fingers joining together. I guess I'm not on camera, so that people can't see this, but just tapping. So in Australia, they had laryngoscopes with tabs so that with the augmented reality software, you were intubating, you were seeing the anatomy of a human, and you were intubating, and it could see where you were moving the laryngoscope, how you were putting in the intratracheal tube. So I think that the technology is going to get quicker, the processing is going to get quicker, the fidelity of the visual is going to get better. The question is, do we have enough market share in EMS, enough people who need this in emergency medical services, that we will get enough attention from developers and programmers to make these devices as advanced as we would like them. And I often feel like we're trying to game the system to a point of, well, why not just put a mannequin or one of us complaining of chest pain and 3 students together and work it. So I love augmented reality, and I think it's going to be super cool. I'm just, unless the authoring tools get super easy, then the fidelity of the experience gets a little bit weird. And I just want to also remind everybody that creativity at a very simple level. I'm reminded of one simulation exam we were working on. People were worried about needle sticks because you were saying, well, what about a sharp object in this situation? And a simple paper clip can be an IV needle, right? You just need to use your creativity, put the paper clip in the catheter so that the student actually gets practice doing the exact thing. But in fact, the end result is, you really can't hurt yourself. So the lack of creativity and the desire for the technology to solve the entire thing is part of the problem. That's the augmented wonderfulness is couldn't you have enough creativity so that the hybrid tools and reality and the technology blend, but you don't need technology to do all of it. That's the beauty with things like iSimulate, where you're actually putting leads on a human, but the EKG is really coming out of an iPad. So it's getting that creative about what do we need the mannequin to do, and if compressions and feedback from compressions is actually really critical. Great, but then the augmented piece maybe comes in when we intubate and see a much more realistic airway.
Yeah. Can you check the Q&A? It looks like we've got something in the Q&A too.
Okay.
I think from an instructional perspective, when you're running really short on instructors or if you have instructors and you have problems with innovator reliability and that kind of thing, this is a very attractive option to be able to integrate some degree of, and then also the ability to be creative and add different elements that you can't do if you have static, volunteers. Your volunteers are going to be young, healthy people, right?
Yeah.
So
sounds will always be clear.
Yeah. So exactly. Can I put this, now I can create, diverse patient or an elderly patient or, all of these different things with a, keystroke, right? So rather than having to have, Joe put on a wig and that kind of thing and be an OB patient. Yeah.
But everyone still knows it's Joe. I think great question by Evan in the Q&A, looking at longitudinal studies. And I think this goes back to Megan's point that we're probably not there yet. I certainly don't have any off the top of my head in EMS training. There's probably some in the healthcare field.
Well, this is actually a great one for Erin, because one of the questions I asked Erin about her study on VR was, did the students eventually get used to the platform and the environment, and it became less, the technology fades away and it's more about the clinical decision making? And I don't know if you want to speak to that, Erin.
There's always going to be a learning curve with new technology, right? Change is hard. But it's also necessary. There is a curve to it, but because they have authored cases that show you where the buttons are and show you how to do these things, I find that it takes 1 or 2 steps before they figure out, I have to put gloves on or they'll fail me. I have to ask all the assessment questions or it's going to fail me. They start to put together the fact that there's a specific way to do assessments. There's a specific order to ask questions, specific questions to ask for specific patients very quickly. And I think that pulls them out of the fact that they have goggles on their face very quickly. It's a very cognitive process. They have to think about what they're doing and put it in a good order. And that process pulls them out of the fact that they're playing a video game. If it's complex enough, they stop worrying about clickers and they start thinking, how do I pass this thing?
I think they made this comment here. Yeah. So it has to do with forcing you to slow down and think. It's almost like forcing deliberate practice, effortful practice, to have to go back and say, oh, if I'm, I haven't put my gloves on. Oh, I need to ask all of the questions in the assessment. And that was some of the comments that were made in here about, this is actually, and they said, the next generation is going to be light years ahead of us, which I loved. But they were talking about how it forced, actually what they commented most on was the interpersonal and scene management skills, task prioritization, delegation, and closed loop communication. And that I think they didn't really expect that to come out of this. And that's what came out of one of the themes.
I think it's interesting. That's probably not what they expected going into it, right? They were expecting to monitor these people on whether or not they like this technology, and probably a little bit, can they manage this patient, right? And then all of a sudden we're like, well, the scene management didn't really matter. It was the fact that you worked well with your colleagues. And all of a sudden we're like, gosh, we're teaching something that we didn't know we were. And there's student knowledge acquisition here for something we didn't even plan for, which I think is great. So now we figure out, okay, how can I test for scene management and delegation skills and also monitor their ability to treat a hypoglycemia hypoglycemic pediatric patient.
Some of that happened during COVID.
Yeah.
When we all were forced to be remote. And I remember, Katie presenting that case that she did with Bill Toon being the patient on Zoom, having patients, Hillary Gates being a patient on Zoom.
Yep.
And suddenly we found the value of being able to, communicate with patients. Role play could be done virtually and recorded. So, things that surprised us that we didn't think we were going to be able to pull out, which is great. It's great when learning emerges like that.
Especially when we don't expect it. Yeah, right.
Yeah.
We do have 5 minutes left, so I wonder if maybe we should do final takeaways from the paper before we wrap up and let everyone go to their next section.
Yeah, if anybody from the audience has questions, we'll try to repeat them if you guys can't hear it online. Thoughts? Anybody here use augmented reality or tried virtual? Been down in the exhibit hall with all the different VR people?
I
Yeah.
tried the virtual.
Yeah.
It's very interesting. And I thought it was pretty well done. And I think it could be used in a lot of different contexts, but we do have to evaluate the efficacy first.
Yes, evaluating the efficacy
But I
of,
think it have pretty strong impacts for both research, especially about disparity in EMS and also education.
yeah. So the comment about, and this from Delaney, right? Yeah. Is that this virtual reality has potential for, changing things when it comes to diversity in EMS, and also just testing the efficacy of it is important. So I think that's going to be, that'll be always what we're doing. Thanks to people like Aaron and Rob Terrio and other people that are doing all kinds of amazing work in this setting. And, it's not just kind of the coolness factor or the expense factor that we want to always be kind of coming back to, but again, back to that translational science. So I think they positively evaluated all the usabilities and addressed some areas for improvement. And they're heading to the next step, which is, seeing if it can scale up and be usable and change clinical behaviors. Be interesting to interview these same people later, have you run a pediatric, seizure and did this,
I was wondering that
impacted.
too. Could we do a 3-month follow-up? Now, a pediatric seizure call doesn't happen every day, but it would be interesting to survey them again, or do a adult cardiac arrest, which we know in the next 90 days, most providers in a service of this size will likely run into. Did it help you at all? And again, I think running this simulation would make you better at doing chest compressions and giving epi and your algorithm. But the study demonstrates that it actually made you better at being a team player and delegating. So again, I'd be interested to know if that actually bears out in the real world as well. So I just appreciate the authors providing us everything so that this study is recreatable, it's usable, everything is in here. If you wanted to do this in your continuing education setting, you could repeat this in initial education as well. So I always appreciate when the authors share as much as they can so that we can recreate it, and this gets the ball rolling. I always like it when something new and shiny actually proves something and improves our outcomes for our patients. So
I appreciate the EMT level, and I think that would be great to integrate to EMT. You have a large number with EMT students as well, so you could get really some powerful analysis going. Okay, well, thank you all for coming to us live from EMS World Expo in New Orleans and at the International Scientific Symposium, which has been a phenomenal event. We're all getting ready to go home.
And a huge shout out to all the people that brought research, contributed to research, came in, listened to research, listened to the poster walk. We had to split the groups up. In fact, we had so many posters. So if you're interested in research, we want to know about it.
Yeah. Congratulations to all the researchers and to these researchers who did the study that we looked at today. So our next pre-hospital care research forum, Education Research Journal Club, will be on Friday, October 27th, 10 a.m. Pacific, noon Central. So thanks for joining us. Our next clinical journal club with Dr. Remley Crow, Dr. Tony Fernandez will be Monday, October 9th. So to join us live each month, you can go to prehospitalcare.org, and you can also find our archives on YouTube. So if you missed any of these, you can go back and watch them, youtube.com/@PCRF@UCLA, and we will see you next time.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.